Hey, Kristen, you're muted in the WebEx.
Oh my goodness, that is bad. All right, can you guys hear me now?
Yes.
Okay, perfect. Let's start over. So, hi, my name is Krista McLaughlin, and I am the Medical Informatics Director for the OMH Office of Population Health and Evaluation. And I'm joined today by my colleagues from the Office of Hospital Care and Community Transitions. And we're going to be discussing the PSYCKES primer for emergency department staff today. So before we get started, just a couple housekeeping tips. As you might have noticed, all phone lines are muted to prevent background noise. But if you do have a question, we encourage individuals to access the Q&A box, which is going to be located to the right of your screen. But if you've expanded the screen for your webinar today and you have it on full screen, you'll just need to hover your cursor over the top center of the screen and choose from the menu option Q&A. You'll want to type out those questions and submit to all panelists, which is the default. You don't want to just submit to the presenter because I might be busy presenting and miss your questions, whereas we have colleagues on the line today to help assist with the Q&A feature. We do ask not to use the chat function for Q&A as that will not be monitored during today's training. And if we do not get to your question during today's training, don't worry, we'll make sure to follow up with all of the users today, as we will be providing the recording from today's training webinar, the slides, as well as additional training materials. So we have two of these trainings, one taking place this week and another taking place next week. So likely next week, that's when we would be providing the recording and all of these materials to everybody who's attended. All right, so talking about the agenda, we have the why now, why PSYCKES, so a little details about why we have hospitals using PSYCKES right now. And then I'll do a brief overview of the PSYCKES application. We might have a mixture of people today, those that are super users who have used PSYCKES often versus those who are just hearing about it. So just getting a little bit of an overview as a foundation. And then talking about how to log into the application, how to access patient level data, how to review that patient level information within the PSYCKES clinical summary, and also looking at some of the other training and technical supports that we provide our users. And we do have an appendix just because we only have an hour for today. So additional details related to obtaining or activating tokens, withdrawing consent, and the PSYCKES mobile app. Although we might not have time to get to it today, we will be including those slides as part of the appendix. All right, so I'm going to turn it over to my colleague, Dr. Flavio Casoy, to give a little bit of background about why now.
Thank you, Kristen, and thank you everyone for joining. This is a webinar aimed at folks who work in emergency departments in a frontline capacity. You are sort of taking care of people in and out, and it's like a really heroic work, and it's super important, and I really appreciate all that everyone is doing. It's you hold a tremendous place in the healthcare system. I know that you all know that, but I think it's important to say. So what happened? So about just over a little bit more than a year ago, there were new regulations that were put in place around individuals who present to emergency departments with behavioral health conditions, so mental health issues, addiction issues, because of there had been sort of a certain number of sort of high profile bad outcomes that were in the press, and Department of Health, Office of Mental Health, sort of worked to see if there could be some regulatory efforts to try to prevent some of those outcomes. So so these new regulations were put in place, and what do they say? So for anyone who comes to an emergency department with a behavioral health condition, there's a requirement for there to be a evaluation for suicide risk, violence risk, substance use. But in addition, one thing that's very new is to determine if an individual sort of meets the definition of something called having complex needs. And the definition for having complex needs is in the regulation, and it includes sort of a number of things. But one way that we developed to help ease the work in doing this for the field is we built a flag into PSYCKES, which is this online system that Kristen will talk about. PSYCKES can indicate whether this individual has complex needs, but also PSYCKES is able to show what other services this individual receives, and help sort of the emergency room determine, where to get more information or what types of medications this person is on, and so forth. Additional requirements for emergency departments that are in hospitals that have an inpatient psychiatric unit, when they are discharging from the emergency department individuals with complex needs. So it's not every emergency room discharge, it's not every discharge of patients with behavioral health needs, it's just discharges of those individuals that have complex needs from EDs that are in hospitals with inpatient psych units. We call these hospitals 939 hospitals. There's a requirement to coordinate discharge planning with care managers, and PSYCKES can show if the person has a care manager. And there's a requirement that the person must have a scheduled aftercare appointment within 7 calendar days. And PSYCKES can show if this person is receiving services from an outpatient provider, and that can make it easier to locate that appointment. And then it also requires the emergency department to send a discharge summary or discharge note explaining what happened, like what were the treatments and what were the assessments in the ED to that aftercare provider, and the contact information can be found in PSYCKES. So there's a new set of regulations. We hope that this webinar and other educational efforts that are coming will help make it easier to implement them, and sort of give you a venue to ask any questions or ask for help in implementation in anything that you need. So thank you for everything that you do. Thank you for joining us, and I'll pass it back to you, Kristen.
Thank you, Flavio. So that leads really well into the next slide, right? So how PSYCKES is helping with these new regulations. So we're able to support patient record review by integrating all different sorts of data that's available across the state for a single individual. We're able to flag those individuals that meet that complex needs criteria, as well as identifying any existing care management or outpatient provider services, as well as the level of engagement in that care. And then also the ability to securely share information like a discharge summary or other documents, which can be uploaded directly into a client's clinical summary. So below we have some stats here. So close to 80% of all New York State hospitals already have PSYCKES access, and there's over 2,700 emergency department or CPEP self-identified staff using the application, and well over 4,000 psychiatric inpatient staff PSYCKES users. So we already have some users already in the application, but definitely looking to expand that. And hopefully this training will help folks get a little bit more details about what PSYCKES is. So let's talk about what PSYCKES is. So the PSYCKES application is an online web-based application that's secure and HIPAA compliant. And the purpose of PSYCKES is for sharing Medicaid claims and encounter data, as well as other state administrative data. And we do this by putting it into a user-friendly format. And the application's designed to support the data-driven clinical decision-making for an individual client, as well as quality improvement for a more population health level of work. Some of the data that we have available in PSYCKES, our largest data source is Medicaid claims. So we're able to get data and we're getting a feed from DOH on a weekly basis of Medicaid claims, which includes hospitalizations, outpatient and inpatient services, care coordination, residential, etc. But some of the information that you're not going to be able to get from Medicaid claims is that it's going to tell you what was paid for, not the associated clinical documentation. So for example, we'll be able to say that a client had an x-ray or had a lab or had an outpatient visit, but we won't be able to have, let's say, for example, those labs, the results. The only lab results that we actually have are coming from state PC data because we have data sources outside of Medicaid claims. So let's talk a little bit about some of those data sources. So outside of Medicaid data, we also get electronic medical record data from the state psychiatric hospitals, which includes general and behavioral health diagnoses, admission and discharge dates, medications, and what I mentioned were the lab values, which is a little bit different than what we're getting from Medicaid. We also have data that we're getting related to health home enrollment and care management provider information, and we're getting that directly from MAP. So if a person is an outreach or enrollment, we have the name of the health home and we have the name of the downstream care manager provider as well as contact information. We're also getting data from an incident reporting system in the state called NIMERS, so you're able to see suicide attempt information. So unlike Medicaid claims where the look back period is the last 5 years, data from these other data sources aren't subject to that 5-year look back. So if somebody had a suicide attempt that was documented in NIMERS 10 years ago, 12 years ago, we're able to display that information. We also have information related to court-mandated outpatient treatment, so order dates, treatment teams, so that AOT, involuntary outpatient commitment, we have data for that. We also have data related for children and adult integrated reporting system, also known as CARES. So you'll be able to see client-level data on individuals receiving some high-intensity outpatient and residential services, including admission and discharge dates, demographic information, and program-dependent instrument and risks. So that's including ACT, PROS, and residential programs, as well as some care management. We also have New York City specific data, and we're getting information from the Department of Homeless Services, which is including shelter and outreach, shelter name, program type, placement date, exit reason, as well as shelter director contact information. We also have information from Correctional Health Services, which includes jail admission date, discharge date, release to, placed in jail mental health residential treatment. So while they were in Rikers, for example, you'll see if they had mental health residential treatment while there, if applicable, as well as behavioral health diagnoses, medications at the time of discharge, and if there was any scheduled follow-up or referrals provided. And then one of our last data sources that we have for the city comes from the Department of Mental Health and Hygiene. So we're getting client level data for intensive mobile treatment, for a mobile crisis, and AOT referrals under investigation. And then lastly, we have data that's being entered in by providers or by patients themselves. So things like advanced directives can be uploaded directly into the clinical summary, or discharge plans, safety plans, even screening such as the CSSRS or PHQ-9s. Those can be administered, and then those results can be added to the clinical summary. So currently we have over 12 million patients that are viewable in PSYCKES, which includes those who have Medicaid-funded behavioral health diagnoses or treatments, the state psychiatric center inpatient, outpatient, those who have received those services, and then those who are in either health home outreach or enrollment. So what you're seeing here is the brief clinical summary. So as part of a previous high-risk quality collaborative that certain hospitals participated in, OMH conducted site visits with CPEPs and EDs to gather information on how users were currently accessing the clinical summary, whether they were getting a printout, if it was uploaded into the EMRs, if they were logging directly into the PSYCKES application, as well as what users found useful or valuable in regards to the data within the clinical summary. So information that we were able to gather from these feedback visits, we found that users wanted to have the most critical information that was easily identifiable, be able to optimize the time when reviewing the clinical summary to get that full clinical picture, and have it be able to fit on a piece of paper, especially if it's from printed. So we took all of the information from the clinical summary and created what is known as the brief clinical summary, which acts as almost like a cover page to the rest of the information that you can see. But some of the information that you're able to see on the brief clinical summary is current care coordination, patient information up at the top here, any notification. So if somebody's hitting a complex needs, you'll be able to see that right at the top of the brief clinical summary. You're also able to see diagnoses from the past year. So what were the 5 most recent versus the 5 most frequent? Then you'll also see medications from the past year, outpatient providers from the past year to get a sense of what their utilization is, and then all hospital and crisis utilization with an expanded look back period of the past 5 years. So able to see the number of visits based on type and broken out between ER and inpatient. All right, so let's start with how hospital staff get PSYCKES access to begin with. So hospital obtains PSYCKES access and begins to register hospital security managers, because it's up to the security managers to determine who at your hospital should be granted access to PSYCKES. And we had 2 previous trainings earlier this month with hospital leadership to go over what this process looks like. So as I mentioned, we have about 80% of hospitals in New York State who already have PSYCKES access and have security managers registered. So we expect all hospitals to have access by the end of this year. So if you're trying to determine if you have PSYCKES access or how to request PSYCKES access, you'd want to ask your supervisor or your administrator who is your hospital security manager. Or you could contact PSYCKES Help to find out your agency's security manager. There is a third way that folks can look at this information, and this is the PSYCKES Hospital Access Users Table. We provided this table to our hospital leadership attendees, and we will be also providing it to the folks on the phone today, because using this table, you can determine using column I here is if your hospital already has PSYCKES access, yes or no. And if yes, if you have any active security managers. If you do have active security managers, you can come to the second tab here and you can search for your hospital's name, and it'll identify who the security managers are for that organization or for that hospital. So you'll be able to identify, like, who am I supposed to be contacting to get this access? Now, if you don't see security information or security manager number here, or you don't see your PSYCKES access has been granted yet, that's something that your hospital leadership is probably already looking into getting that secured. But you can always reach out to our PSYCKES help desk if you have additional questions. So once you've contacted your security manager to request that you be granted PSYCKES access, staff will then obtain and activate a token, and those steps for what that process looks like is included in the appendix at the end of this training. And then you'll just want to make sure that you're able to log into PSYCKES for the first time. So I do want to emphasize, again, as we did have this training with leadership staff earlier this month, is that your hospital is going to be determining what protocols and procedures they want to follow when it comes to implementing PSYCKES at their hospital. So it's always really important to be asking and keeping in contact with your supervisors or administrators to determine what your hospital's approach is to implementation, but always knowing that the PSYCKES help desk is here to provide additional support when needed. All right, so let's talk about how to log into the application. So you can go to the PSYCKES homepage, and this is what the homepage looks like, and then you would select Login to PSYCKES, this button right here. We do recommend that folks bookmark the PSYCKES homepage and not the login, just because if in the future, if the URL would have to change for that login for whatever reason, your bookmark no longer is going to be usable. Whereas if you have the psyches.org or psyches.com bookmarked, you'll be able to quickly go from there and select login to Psyches. So for the sign-in selections, you have to identify what type of user you are. Are you an OMH state provider user, or are you an external local provider, which is a non-state? So this would be the selection that our hospital colleagues would be making. And then from here, with the credentials that you've been provided from your security manager and you have already obtained and activated your token, you would indicate your username here. And then for your passcode, here's an example of what it looks like with a mobile token. It's a two-step authentication. So you would have to first enter in your PIN, which is an 8-digit code that you create that only you know. And then once you've entered in your PIN and submit, every 60 seconds, a new passcode will be showing on the screen. So you would use the information you're seeing in the passcode to put into the passcode box down below here. All right, so once you've entered that information, you should land on a page that looks like this, and there should be a box that confirms that you're logged in as your specific hospital. So you need to agree and abide by the standards indicated for federal Medicaid confidentiality, and you could continue with your login. During your very first time logging into Psyches, you're going to get prompted to answer a brief survey of 3 questions. It's going to ask you what your role is in the hospital, where you work, and what your primary work setting and program type is. So you would complete that information. For example, I mainly work in the emergency department CPEP, but sometimes I go on mobile crisis calls, for example. So here's an indication where you can make up to 2 selections here. And then you would continue to Psyches. On an annual basis, you'll get prompted to update your user role survey, but if there's no updates, you can just continue to Psyches. But if there is an update, you can always go in and make these changes. All right, so let's talk about how to access patient level data. So there's 2 different ways that a patient can get linked to your hospital. So the first way that a client can get linked to a hospital is through billing from Medicaid claims. So if a patient has a billed service anywhere in the hospital within the past 9 months, they'll automatically be linked to your hospital. Meaning, like if I'm running a recipient search and I'm trying to identify like who at my hospital has complex needs, this person that your hospital is billed for in the past 9 months would show up in that recipient search. However, it wouldn't necessarily allow you to access their clinical level data. And that's what's going to be required for the manual linkages. So being able to drill down to the clinical summary to see individual level information. So the provider would have to attest to one of the following: that the patient has signed either a Psyches consent, a DOH health home patient consent, or a BHCC consent. We also have a verbal consent. So during the COVID-19 pandemic, we created a verbal consent policy to allow for hospitals or other providers to access information when a client couldn't physically be there to sign, having the ability to verbally enable consent, but would not have the same level of access as a written consent. There's also clinical emergency, a break the glass scenario, when the client is in imminent risk of harming themselves or others. And then the patient is currently being served by or transferred to my hospital. So if a client hasn't signed the consent and it's not a clinical emergency and my hospital has not yet billed for this person because it's the first time that they've shown up, there's this other option, which again would link the client to your view, but wouldn't allow you to look into their clinical information. So this slide kind of goes into more detail about what the different levels are. So the signed consent is the highest level because it allows access to all available data, including data with special protections like substance use, HIV, family planning, and genetic testing. And it allows that access for 3 years after the last billed service. So if this person showed up to your hospital, anywhere in your hospital, if it was in the outpatient clinic or in the emergency room, for example, and a signed consent was enabled, that means any of the hospital users at your organization would be able to access this information for the next 3 years potentially. So this is always a good tip when you're looking at PSYCKES, is to first search for the client to see if a consent has already been enabled, and that way you don't have to go through that process again if it's already been done. Then there's the verbal consent, which allows access, but for a limited amount of data, excluding that specially protected data, and that would only be available for 9 months. Then clinical emergency, this is probably something that's going to happen most frequently in the emergency departments, right? So this is a break the glass scenario, which would allow users access to all available data, including data with special protections, but for a limited duration of 72 hours. During that time, the clinical summary can be exported and uploaded into your EMR, can be viewed, but after that 72 hours elapses, when you try to look into that client's information in PSYCKES after that time frame, it's going to revert back to whatever the previous level of access was. So if it was no access before then, after 72 hours, it'll revert back to no access. So the vast majority of, as I mentioned, the ED presentations are likely going to be clinical emergencies, but we do think obtaining signed consent is a good practice and would be greatly appreciated by your colleagues in the inpatient unit, so in other places within your hospital, because again, when you get a signed consent, that's good for 3 years and doesn't have that 72-hour limitation. And then attesting to services will link your client to your organization or to your hospital for those recipient search reports, but won't provide you access to the clinical summary. Oops. So this is what the PSYCKES consent looks like. So it includes a brief overview of what PSYCKES is, the types of information providers can see if a patient grants them consent, a place to indicate if the consent is given or denied, and then a space for the patient's name, date of birth, Medicaid ID, and their signature to confirm their choice. So when a PSYCKES consent is completed, always want to make sure that the hospital is uploading that or saving that to the client's record, and then a copy is being provided to the patient themselves for their own records. So in order to access the pre-populated PSYCKES consent form, which would indicate the name of the hospital as well as who should be contacted for individuals if they think that their data has been improperly accessed or if they want to withdraw their consent, that can be done by going to the Registrar tab and into the Manage PHI Access sub-tab. So right under here, Registrar and Manage PHI Access. So from within there, you can go and get the pre-populated consents in English or in Spanish, but we also have other languages, I think up to 10 other languages most spoken in New York State. So as always, staff should follow their hospital's protocols on how to access consent forms. For example, including the PSYCKES consent form along with other registration intake forms, paper electronic formats, etc. So your hospital might have a protocol where the administrative staff would be responsible for collecting consents versus clinicians. So it's really always important to make sure that you're staying aligned with your hospital's protocols. All right. So let's talk about how to look up an individual person and enable access. So you'd come to the recipient search and you see up at the top here, there's 2 different tabs. You can do an individual search to look up one person, or you could go over here to cohort search if you're interested in looking at a group of patients that have been served at your hospital. So for the purposes of this exercise, I'm trying to enable access to a single person. So I'm going to use individual search, and I would enter in one or more of the recipient identifiers. So if I have a Medicaid ID or a Social Security number, that's the first thing listed here, which is a unique identifier. So that would hopefully be able to only return one client with that information or one patient, but sometimes that information might not be available. So you do have the option of using the combination of name and date of birth to identify that person, but you want to be very careful because there could be, you know, a lot of different John Smiths. So if you want to be able to add known client characteristics to help narrow the search, you have the ability to do that below as well. So this is the individual search is how you'd be able to look up one specific client. So on this second step, you want to confirm that the search identifies that correct person. And a new feature that we've just added earlier this month is this planning considerations tab here, which would help you identify if somebody is hitting complex needs. So for example, Jane Doe, I can see on the far right of my planning considerations has complex needs. I've already been able to identify that even before going into their clinical summary to be able to see maybe what are the reasons they're hitting that flag. So always pay attention when you're doing your recipient search to the planning considerations box, because that'll help you identify some of those complex needs individuals without needing to search for them specifically. So if you're looking at this information, you see anything where it's like, actually, Jane Doe, that's not the birthday or that's not her address, you would want to make sure that you're modifying the search, because it doesn't help to enable access to not the patient that you're serving, because the data isn't going to be applicative to them. But if I determine Jane Doe, this is the Jane Doe that I'm sitting in front of and I'm trying to enable access right now, I would come to the far right and select Enable Access. So over here, the next thing I have to decide is what is the appropriate level of access. So I have the ability to look at more details of all of the different access levels, but the first question is basically asking, did the client sign a consent? And if so, what consent? If the client didn't sign a consent, what are the other reasons I might be able to access this information? The client gave their verbal consent, or this is a clinical emergency. So here's an example of, I'm going to say like this client signed the PSYCKES consent form and I'm going to hit next. So steps 4 and 5 are confirming the identity one last time and then enabling access. So again, just confirming one last time that this is the Jane Doe that I'm sitting in front of right now and I need to enable access because they're the ones that signed the consent. And then I have to identify how would I know that this is the correct person. I either attest to the client's identity, I'm familiar with Jane Doe, I know this is Jane Doe, or Jane Doe provided one form of photo ID and I would indicate that photo ID, or two forms of non-photo ID, and I would indicate that using the drop downs here. And then at the very bottom, you're going to see a summary of what level of access Main Street Hospital or your hospital is eligible for. So I'm going to be given access to all available data for 3 years, which renews automatically with billed service. And so I can enable and go back. Maybe I have other consents I need to enable for patients that I'm seeing, or I could enable and go directly into Jane Doe's clinical summary. So I just hit enable. So here's an example of me landing right back on my recipient's found page. And now the current PHI access has been updated to PSYCKES consent. I do want to just make a couple notes about breaking the glass in clinical emergencies, because if a patient does refuse or is unable to sign a consent and they are having a clinical emergency, the providers are permitted to obtain PSYCKES data without consent vis-a-vis the breaking of the glass scenario. So the clinical emergency is defined as a medical or behavioral condition of which there is an immediate need for treatments and symptoms are sufficient in severity that the absence of immediate treatment would likely result in serious harm to self or others. So below are some of the different criteria for breaking the glass. So threats or attempts of suicide or serious bodily harm or other conduct demonstrating dangers to themselves. Homicidal or other violent behavior of which others are placed in reasonable fear of serious physical harm. Inability or refusal due to mental illness to provide for their own essential needs such as food, clothing, necessary medical care, personal safety, or shelter. And then overdose, sedation, altered mental status, catatonia, and otherwise non-responsive. So providers are going to be responsible for ensuring that the medical record supports emergency access by documenting why and how the client meets criteria for clinical emergency and attesting with their signature, date, and timestamp. So these are things that providers would do within their EMRs in case there's ever, a question later on where a client asks why was their data enabled or accessed, and you can have this to fall back on for audit purposes. All right, so let's talk about the clinical summary. So the clinical summary summarizes up to 5 years worth of treatment history for a client. So that 5 years relates to the Medicaid claims information. But as I mentioned earlier, some of our other state administrative databases can go back to a further look back period. And it creates an integrated view from all of these different databases into and summarizes that information into treatment episodes to help support rapid review. And episodes of care are linked to detailed dates of service, including diagnoses and procedures. And so it's organized in a way almost looking like an EMR record. And clients, again, clinical summary would help providers with identifying those patients with complex needs. So not only identifying those patients, but seeing what criteria they're hitting that makes them complex needs. Identifying patients that have a pattern of ER visits but aren't engaged in maybe community care, form a differential diagnosis by clarifying history of patient care and services, and obtaining contact information in order to coordinate care and referrals. So I included a slide here for complex needs. So here are all of the different criteria that a client could hit that would make them or consider them complex needs. So general criteria would be for any age. If they hit one or more of these, they would be identified as complex needs, as well as some additional eligibility criteria for children and adolescents, so from 0 to 20. So this could be information that for that age group would make them eligible for complex needs flag. All right, so we already looked at the brief overview. So that's what you're going to land on when you first drill into the clinical summary. You're going to get a brief overview where you can identify certain things right off the bat. So for this client in particular, I can see that they are enrolled in a health home, and I can see what health home that is, when they began, what their status is, and what are some of the contact referral numbers or contacts that I can reach out to, as well as who they're enrolled in for care management. And then under the notifications, here is where I can see not only that this person's complex needs, but I can see why they're considered complex needs due to Health Home Plus eligibility, being ineffectively engaged, having 4 or more ER mental health visits in less than a year. So some of this information that you're going to be able to see, and what you're going to be able to see in the clinical summary that supports these findings here. And you have the ability to scroll down on this brief overview. And here's an example of outpatient providers. So what were some of the outpatient providers this person has been in connection with in the past year? So you can see there's different clinical medical specialties here, physician groups, urgent care, but not any mental health services. So that might be something that's a gap for them. And then you can also see their hospital and crisis utilization over the past 5 years. So you can see what their most, how many ER visits they've had in the past 5 years due to mental health, at how many different providers, as well as what their last ER visit was and where was it. Then you can switch over to the full summary, where you can see more detailed information related to this person's, depending on what section that you're interested in. So the full summary will show all available data that we have for these individuals. And you have the ability to export the PDF, for example, and put that into the EMR record. And you'll see when the last date of refreshment is. As I mentioned, we update this every week. And then you have the ability to also export to an Excel. All right, so we've already talked about care coordination and notification information. So what are some of the other data sources or data sections that we have in the clinical summary? So in the alerts, you'll be able to see any alerts related to suicidality, overdose risk, or homelessness. So in this case, we can see that this person has had multiple treatments for suicidal ideation, and it'll provide the most recent information there, as well as the provider name and the severity of the severity diagnosis, medications, or results, depending on what type of alert it is. And then beneath that, I can see that this person had a positive CSSRS suicide screen, and they had this back a few years back, and this was administered using the PSYCKES mobile app. And here I'm seeing the results of what that screen showed. And down below here, we have social determinants of health. So the data source that we have for SDOH right now comes from Medicaid billing Z codes, and hospitals are great at including those Z codes on claims versus maybe some other outpatient providers are not as adding those as much as maybe, let's say, hospitals. But we're hoping to expand this data source in the future to be able to expand the amount of information we are able to share, because this is likely underreported because it's only coming from Z codes. However, you are able to see if there's information for the different types of conditions. So for example, problems related to housing and economic circumstances, we can see that this person has had homelessness indicated somewhere in their billing in the past, as well as unemployment. And you have the ability to click on these different SDOHs to identify like which providers, billed for that Z code or identified that as a potential issue. Then you have the quality flag. So PSYCKES identifies flags for clients with particular quality concerns in order to alert clinicians of possible unmet clinical needs. So some examples here you can see is that this person is eligible for Health Home Plus but hadn't received any Health Home Plus services in the past 12 months. Or that they're high utilizers, that they've had 4 or more inpatient or ER visits for behavioral health purposes in the past year. So you're able to get the definitions for any of these flags, as well as select the flag themselves to get the definition if you'd like more details on that. And then we have plans and documents. So here's a place where you can view any other plans or documents that have already been uploaded by different providers or by the client themselves. You can see that information. So you'll see the date the document was created, what type of document it was, the provider who submitted that, the staff of that person, and what their role is. I also have the ability to upload a plan myself. So we were talking before about a discharge plan that hospitals may want to be able to share with providers, especially when on discharge. So you can come to this upload button, hit this drop down and make a selection. And if none of the options below fit, you also have the option of putting other and putting more details about what that other is. And you can upload that information, and any other providers or any other PSYCKES users who have consent to view this client's information would then have access to this information. And you also have the ability to create new using one of our templates. So right now we have the Stanley Brown Safety Plan template available, and then we also have the NIAPR's Psychiatric Advance Directive as a template. So if you want to use one of the templates that we already have available to create and then upload, those are options that our users do have. All right, and then comes the diagnoses. So here's an example, unlike what you're seeing on the brief, where you're seeing only the 5 most recent, the 5 most frequent in the past year, this is going to show the most frequent first, and it's going to show for the past 5 years. So for example, I'm seeing that schizoaffective disorder is the diagnosis that's given most frequently for this individual. So I could select that, click on that specific diagnosis and see dates of service, service subtypes, provider name, as well as any other related diagnoses that they had for that claim. And then the integrated view of services over time. This is basically taking all of the data that's available in the clinical summary and putting it into a graph format to allow for the identifications of certain patterns or gaps in care. And when you hover over, for example, this dot here, I could see what that specific emergency room medical visit was. It was at Samaritan Hospital on 2/14/2026. So when I'm seeing a continuous line, that means continuous service. So this person has been enrolled in Medicaid since prior to July 2021 and has not had any breaks in that Medicaid enrollment. Whereas the individual dots that you're seeing here basically mean that these are like one-offs. And I can see that they're very adherent with picking up their medications until we get to about July 2025, a little over, then there's a little bit more gaps in care, but then higher emergency room visits. So that could be something to point out. I also might notice that there's a lot of emergency room and inpatient stays, but not a lot of outpatient services. So maybe I want to get this person linked to outpatient community care in order to help limit the amount of emergency room visits that they're making. Then you have medications. So this is going to include controlled substances, behavioral health, or medical. You have the ability, just like with any of these other sections, to toggle between a graph or a table. This is the table view here. So I would have the ability to also, let's say, for example, this first medication here, this first antipsychotic, I could also drill into details and see information about each individual order or every individual pickup to help identify like how many times in the past almost 2 years for this person they've been picking up this medication. And then we have outpatient behavioral health and medical services. So those broken up into behavioral health and medical. So I have an understanding, for example, in this individual has had 10 visits to the CCBHC. And their most recent visit, they were given the diagnosis of bipolar, and it gives a little bit more detail about what are some of the procedures that are occurring during these visits. And then you have the same for some of the medical outpatient, where you can see first state billed, last state billed, number of visits, most recent primary diagnosis, as well as any of the procedures. And you have the ability, just like for any of these, is to go between graph or table. Then we have a crisis services specific section. So this is going to take information related from residential crisis services as well as mobile crisis services and put them in this crisis services section. So you'd be able to see how many mobile crisis visits somebody might have had, as well as if they've had any stabilization center stays, which we can see here. And then lastly, we have hospital and ER services. So this is integrated. So unlike the outpatient that we were seeing between the behavioral health and the medical, you're going to see that integrated between all of these in the same section. So you can see here that this person had a 14-day inpatient medical visit at Albany. And due to this diagnosis here for a lumbar spinal cord injury, and what were some of the procedures there? And then we can see that this person had some CPEP visits. And here we're seeing unspecified intellectual disabilities. Maybe I wasn't aware that this person had any IDD, so I'd be able to see that not only in the services, but also in the diagnosis section. All right, so I want to spend a couple minutes just talking about some of the training and technical supports, and then I want to open it up to questions. So some of the resources that are going to be sent to individuals who've attended any of these hospital trainings in April or would be available on request includes that PSYCKES Hospital Access User Table that we reviewed earlier. So that would help you identify if your hospital already has PSYCKES Access, and if so, if they have any active security managers, if you want to use that information to contact your security managers to get PSYCKES access. We also have for the leadership action planning forms and other resources used for a PSYCKES implementation. We also have resources for the security managers on how to grant and revoke access to PSYCKES. We also have a PSYCKES consent script. So if clinicians or administrative staff are determined to be the ones that are going to be getting PSYCKES consents or embedding PSYCKES consents into the intake procedures, we have a script that can help explain not only what PSYCKES is, what the consent does, but also some frequently asked questions so you have that to rely upon. We also have a Psyche summary checklist and workflows document. So just making sure that there's some core competencies that Psyche's users are aware of. And then we have resources about how to activate tokens and log into Psyches. So there's two different options when it comes to tokens. The default option is the mobile token, which can be downloaded on any mobile device using the RSA token app. But we also have instructions for the hard token. So for example, if your hospital has policies where cell phones are not allowed on the floor, the security manager would have to go through certain procedures to request a hard token for users and getting that hard token into the appropriate hands of the users. So we have steps to describe each of those different circumstances. And then lastly, tips for how to upload a psychiatric advance directive into Psyches. And that same tip could be used for any other type of document if you wanted to upload. We also have training resources, so that packet will be sent directly to attendees, but we also have training resources for all Psyches users, and those are available on our public website. So if you're more of a visual learner, we have these short how-to videos on how to log into Psyches, how to look up a client and enter consent, how to look at a clinical summary. These are 5-minute videos that might be helpful if you're, again, more visual and would like the idea to like kind of, play that video while you're in the process of doing some of these enabling, especially in the beginning. We also have user guides. So guides that are dedicated to certain tasks or certain modules of the application. So how to enable access to patient level data, how to, view the clinical summary, how to use some of the mobile app information. And then lastly, we have Psyche's training slides and recordings. On a quarterly basis, we update our trainings and offer live training opportunities, as well as posting some of our live training recordings for people who weren't able to make that live training, but wanted to be able to view that information at a later date. So we're going to be putting our hospital trainings, like the ones that we had for leadership, as well as the ones that we're having with you folks today, those will eventually be placed on our public website, as well as how to do some of these other, sources like how to integrate Psyche's consents into workflows, how to use the Psyche's clinical summaries. So we break in our different trainings into either user type, like for example, hospital users, or by module type. So anybody can come learn about how to use recipient search or clinical summary, et cetera. And then what's new? So right on our homepage, you're going to be able to see some of the what's new in our website. So some of those things might include things related to our new releases, which we just had one earlier this month. So you'd be able to see what are some of those new features. And every quarter, Psyches is adding new features to the application. So being able to stay on top of some of those changes and seeing what's new or what new data sources we're able to access. And then lastly, some of the technical support. So if you have any questions regarding the Psyche's application related to data or functionality, you can reach out to our Psyche's help desk, which is available 9 to 5, Monday through Fridays. We strive for a response within 1 business day, and we can also set up calls via WebEx if additional support is needed. We can also have you contact your OCT hospital program specialist or the hospital care at omh.ny.gov, who may be able to do an on-site demonstration for your hospital. And then lastly, if you're having any issues with your token or logging in, you'll have to contact the OMH help desk. And the reason why is because the tokens are for any OMH application, not merely Psyche's. So in that case, to have if you're getting an authentication error message, or if you're getting if your access was revoked and you have questions, you're going to have to go through the OMH help desk, which can be reached at this number, or I think the preferred method would be the email. If you're having any difficulty getting through or getting a response, please, please, please loop in our Psyche's help desk, and we will make sure to get your questions answered and moving to that next step, because we know that logging in, especially the first time logging in, can be a multi-step process, but we don't want it to be the barrier that keeps people out of the application. So with that, I'm going to touch base with Michelle and see if we have any questions.
Hey, Kristen, we did have a few questions come in. The first few were regarding the regulations, so I'll just start with a couple of those. Do the new regulations apply to CPEPs, medical emergency rooms, and non 9.39 hospitals in the same way?
I will give that to
So
Flavio. Yes.
thank you, Michelle. Thank you, Kristen. Thank you for the person who sent that question. So um, there are regulations that apply to all emergency rooms, including non-939. There's maybe a few more regulations that apply only to 939 hospital emergency departments when discharging patients with complex needs. And then there's sort of a separate body of regulations for CPAP. So it's different. This presentation had a focus on emergency departments. When we send out sort of the slides for this presentation, we'll also include a link for a new guidance document that was recently issued by the Department of Health and Office of Mental Health to help answer some of these additional questions. And then, of course, you can always email hospitalcare@omh.ny.gov, which is on your screen, and we can help get you additional answers to questions.
Thank you, Flavio. Just another question about EDs, what they should do for scheduling appointments during off hours, overnights, or holidays when local outpatient services are not available.
Yeah, so this has probably a longer answer than I think we have time to sort of say right now. Let me, in the guidance that we'll send out, there's a whole section on that. And if programs are still have difficulty with this, we can consult and maybe try to broker relationships to try to address some of those gaps.
Okay, thank you so much. I'm going to move to just a couple of PSYCKES related questions that came in. Would PSYCKES include private insurance, managed care, or no insurance individuals, or is PSYCKES only for Medicaid or dual eligible individuals?
That's a great question. So we have a couple different data sources. So it would be managed care fee for service as well as managed care plan enrollees. So managed care is our biggest group. However, we do have data for people who are also in the state PC. So even if they don't have Medicaid, we would be able to collect and see some information related to those who have been served in the state PC. And we also have information for those who are enrolled via the health home or CMEs. We're always looking to expand into the future, but at this time, those would be the limitations.
Great, thank you, Kristen. The next question about PSYCKES is, can I also access population health de-identified data for the region or the state without needing to drill down to the patient level? This would be helpful to look at gaps in care and inform future projects.
Absolutely. So this would be, and I would love to know if this was somebody who is working like clinically with patients or in another role, but the recipient search, what we didn't go into today, where we're looking at the individual search, but you have the ability in recipient search to be able to identify, like, in my region, so or in a region, who are some of the clients that I share with certain other providers or who are hitting certain flags. So I would encourage that user to look at some of our resources on our website, which are looking at some of like the different ways that you can use the recipient cohort search. But I would like to, Michelle, if you wouldn't mind taking a note of that user, because I want to make sure I'm fully answering their question, or if they're thinking about a different type of access for like a
Mhm.
hospital association, for example.
Sure, absolutely. Thank you. I'll just do this one as the last question. It should be a quicker one. Who do we recommend should be assigned the security manager role at hospitals?
That's a great question, and that was one that we went over during the hospital leadership. One of the folks that we think would make a great security manager would be the same people who are responsible for onboarding people into your EMR, because it's very likely similar skill sets, and you would want to have somebody who had that kind of technical background. So that was one of the recommendations that we provided to the leadership group, is that the security manager might be a good person. You'd want to have at least 2 per campus, and have it be the same people who are responsible for, granting access to your EMR for specific staff. So you can kind of do it hand in glove.
Great. Thank you, Kristen. That's all the questions for today.
Amazing. So thanks again, everybody, for taking time out of their day for joining this training. As I mentioned before, we're going to be sending the training slides, the recording, as well as those additional hospital resources after we complete our final training next week. So we'll make sure to send to all of the attendees from today's training, as well as the attendees of the next training. And then hopefully in the not too distant future, just being able to upload all of this information directly onto our public website, so everybody will be able to access. So thank you again, and I hope you enjoy the rest of your day.